Good afternoon, everyone. I'd like to thank the Society for the opportunity to present our research entitled Overcoming the Learning Curve for Robotic Inguinal Hernia Repair. Go ahead. The big green. Dr. Smith is a consultant for Stryker. The other authors do not have any conflicts of interest or relevant financial disclosures. Robotic-assisted inguinal hernia repair is a newer surgical approach that has gained popularity for the repair of inguinal hernias. Approaches include total extraperitoneal repairs and transabdominal preperitoneal repairs, or the TAP method. Reported advantages of robotic-assisted surgery include 3D visualization, improved dexterity, elimination of surgical tremor, and ergonomic positioning compared to laparoscopic and open surgery. Despite the purported advantages of robotic surgery, it is not the technique of choice in the general surgery community at large compared to laparoscopic and open inguinal hernia repairs. One of the barriers to adoption of robotic inguinal hernia repairs has been the learning curve associated with performing a newer surgical approach. The literature on inguinal hernia repair learning curves mostly deals with laparoscopic inguinal hernia repairs and is largely focused on operative times and clinical outcomes. To date, there have been a small number of studies examining the learning curve of surgeons performing robotic-assisted hernia repairs, as this remains a topic of interest. In our study, our objective was to investigate the learning curve of the surgeon when beginning robotic TAP hernia repairs based on operative times. In our study, we retrospectively identified patients over the age of 18 that underwent a robotic TAP inguinal hernia repair at a single institution in the Veterans Administration at Long Beach, California. Our study period was from 2012 to 2019, using a comprehensive database maintained by a single minimally invasive surgeon. The surgeon had no exposure to robotic surgery training and was laparoscopically trained prior to performing these robotic inguinal hernia repairs. Our primary outcome was operative times, which was defined as the skin-to-skin time needed to complete the operation. A cumulative sum learning curve was created based on operative times for both unilateral and bilateral inguinal hernia repairs. Distinct phases of the learning curve were interpreted, illustrating the surgeon's operative variability over time. We performed univariate analysis after stratifying 3 distinct phases of the learning curve into groups for comparison. Here is a representation of the learning curve for the unilateral inguinal hernia repairs with a sample size of 124 patients. 3 distinct phases were analyzed, with phase 1 comprised of 21 patients, phase 2 comprised of 53 patients, and phase 3 comprised of 50 patients. Bilateral inguinal hernia repairs were also analyzed, with 3 distinct phases interpreted, comprised of 40 patients in phase 1, 50 patients in phase 2, and 44 in phase 3. Demographics were analyzed for both unilateral and bilateral inguinal hernia repairs in the distinct phases of the learning curve. Here we found that there was no significant differences amongst the groups for comparison in all demographic variables except for smoking, which was significantly higher in phase 1 patients compared to both phase 2 and phase 3 patients. Here are the demographics in bilateral inguinal hernia repairs. Again, all demographics were similar in comparison groups, except for smoking, which is significantly lower in phase 3 patients compared to phase 1 and phase 2 patients. Postoperative outcomes were also analyzed. For unilateral repairs, operative length was significantly higher in phase 1 patients compared to phase 2 at 78.1 minutes, but not significantly different in comparison to phase 3. All other postoperative outcomes associated with hernia success, such as recurrence, readmission, chronic pain, urinary retention, were similar amongst the 3 groups. In postoperative outcomes of bilateral hernia repairs, again, operative length was significantly higher in phase 1 at 97.9 minutes compared to phase 2 and phase 3 patients. Again, all other postoperative outcomes associated with hernia success was similar amongst all 3 groups. Our data suggested 3 unique phases of skill acquisition according to the learning curve. The first phase of the learning curve illustrated initial acclimation of the operating surgeon, as this phase of learning had the largest operative time average at 78.1 minutes for unilateral repairs and 97.9 minutes for bilateral repairs. The second phase of the learning curve then transitioned to surgical proficiency of the operating surgeon, with operative times decreasing to 61.9 minutes for unilateral and 77.7 minutes for bilateral. The third phase of the learning curve was associated with slightly higher operative times, with unilateral repairs taking 69.2 minutes and bilateral repairs taking 85.1 minutes, which may have been due to the operating surgeon taking on more challenging patients after achieving proficiency. In conclusion, we found that the learning curve for robotic TAP hernia repairs had 3 stages of learning. Proficiency and expertise may be achievable in 74 cases for inguinal hernia repairs. We also found that despite learning a newer surgical modality, perioperative outcomes and long-term hernia recurrence were not affected by the learning curve. Thank you.